All right, good morning, everyone, and welcome to the Department of Medicine Grand Rounds, this beautiful, little bit chilly September morning. This is the first Grand Round of this academic year for Hamilton Health Sciences. Last week, we've all enjoyed the Chair Grand Round, and as you all aware, this year we will continue to have combined rounds between Hamilton Health Sciences, St. Joe's, and the University Department of Medicine, so you don't have to decide which one to go to. So we welcome our colleagues from St. Joe's Healthcare System today as well. We are really excited. I'm really excited to hear today's talk, see what's new in this, So our speaker today is Dr. Sandra Ofori. Dr. Ofori is a cardiologist and perioperative medicine specialist. She completed medical school at the University of Port Harcourt in Nigeria, and followed that by internal medicine residency and general cardiology residency training at the University of Port Harcourt Teaching Hospital in Nigeria. She holds a master's degree in preventive cardiology from Imperial College in London, UK, and she completed a fellowship in perioperative medicine at McMaster University, Hamilton Health Sciences, and is completing PhD in health research methodology at McMaster University. That's a very impressive track record so far. Dr. Ofori is one of, probably many of you know Dr. Ofori, working with her in cardiology and medicine, and she's one of our new recruits. She's currently an assistant professor at McMaster University and a consultant cardiologist at the Jervinsky Hospital and an investigator at PHRI. Her research interest includes, as you may suspect, cardiovascular disease prevention, smoking cessation, and she's also involved in virtual care with remote automated monitoring for non-cardiac surgery. And today, Dr. Ofori is going to be talking to us about smoking cessation in persons undergoing surgery. Sandra, please go ahead.
Thank you very much for that very kind introduction, Khalid. Good morning, everyone. Today, we're just going to be refreshing our knowledge on smoking cessation in persons undergoing surgery. I want to start by saying, even though this is focusing on persons undergoing surgery, most of what we'll discuss today will apply to any hospitalized patient. We'll start by a land acknowledgement. I want to acknowledge that I am situated upon the traditional territories of the Haudenosaunee and Mississaugas. This land is covered by the Dish with One Spoon Wampum agreement between the Haudenosaunee and Anishinabe nations to share and care for the resources around the Great Lakes. Please take a moment to reflect and give thanks to those who have come before you on the lands on which you and I currently reside. I have no relevant conflict of interest for this talk. The agenda today is to start with a brief background and a refresher on nicotine addiction, discuss some of our perioperative smoking work, highlight the current evidence for perioperative smoking cessation interventions, and my ideas for where the research is going. Just as the general background, we know that tobacco is a natural plant and nicotine is the psychoactive molecule in tobacco. There are many forms of tobacco use all over the world, but by far, the commonest way that tobacco is used is through cigarette smoking. So in this discussion this morning, when I refer to smoking, I'm referring to cigarette smoking. There are many ways that being a current smoker is defined, but according to Health Canada surveys, we define current smokers as people who are smoking daily or non-daily. And the question is, at the present time, do you smoke cigarettes daily or non-daily? If people have smoked a total of 100 cigarettes in their lifetime and are smoking daily, then they're defined as current smokers. If they're occasionally smoking, then they are non-daily smokers. But if the answer no to this question, then they are never smokers. We know all over the world that over 1 billion people smoke. That's about 23% of the world population from the Global Burden of Disease study in 2019. At least half of all cigarette smokers will die from a tobacco-related illness. Majority of the tobacco-related illnesses are from cardiovascular disease, respiratory disease, cancers, and stroke. In Canada, there's over 5 million smokers, and this is responsible for around 45,000 deaths a year, costing the economy more than $7 billion in healthcare direct and indirect costs in Ontario alone. When it comes to the perioperative setting, the global burden of surgery is increasing around the world annually. Over 300 million adults undergo surgery. With a prevalence of between 15 to 20%, this is around 60 million people undergoing surgery who are smokers. Smoking not only increases post-operative complications, which I'll show in subsequent slide, we know that it's one of the leading risk factors for mortality and morbidity worldwide. And despite, at least in westernized countries, the declining prevalence of smoking in the general population, this hasn't really been the case in the surgical population. And because surgery is a period where patients are sort of focused on their health, it really presents itself as a teachable moment that we should capitalize on to help patients optimize their long-term health even after their surgery. There's so many observational studies that have shown the association between smoking and postoperative complications. But I just want to highlight this one from 2013. It was a large observational study that used the US National Surgical Database. There were over 600,000 patients that were looked at in a respective manner. 20% were smokers, of which 13% were classified as ex-smokers, having stopped more than 1 year in advance. They looked at mortality, arterial events, and respiratory events, and the odds ratio for these events were all higher in current smokers compared to ex-smokers and never smokers. And if you look on the sort of the graph on the left of the screen, you can almost see a trend for those effects, such that people who were heavier smokers tended to have higher odds of mortality, arterial events, and respiratory events. Apart from the morbidity associated with smoking in the perioperative setting, people who are smokers tend to utilize healthcare resources more than non-smokers in the year following their surgery. For example, in Canada, for instance, primary joint replacement, hip or knee, is around $10,000. If you need a revision of that surgery, the cost goes up significantly to about $17,000. Studies have shown that the highest risk factors, or the most predominant risk factors for needing joint revision surgeries, are infection or loosening and instability of the joint. And smoking is a risk factor for post-operative infections in people who have undergone orthopedic surgery. So even if we don't look at just the direct impact of smoking on morbidity, if we think about the fact that providing smoking cessation interventions may reduce some of these post-operative complications, it can be regarded as high-value surgical care. Smoking is one of those things where somehow people sometimes think about it as a habit and therefore minimize its actual impact. It's a chronic relapsing disease like many other diseases that we're used to in medicine. Most people that smoke report that they want to quit, but only very few are able to quit without support. And those who try to quit without support, most of them will relapse within the first week of quitting. If people try to quit without support, only about 5% of them are still abstinent 1 year from their quit attempt. So it's a disease that is chronic, is relapsing, and most people need support to be able to overcome. The reason why people continue to smoke, even despite all of what we know about smoking, is nicotine. So nicotine is the most psychoactive substance in tobacco. It's a stimulant drug. It causes actual changes in brain chemistry. It's highly addictive. And one of the key drivers of how addictive nicotine is the delivery system. So the cigarette is one of the most highly efficient drug delivery systems in the world currently. It delivers nicotine very rapidly through the lungs to the brain in less than 10 seconds. The amount of nicotine per tobacco product or cigarette really varies. So the typical sort of North American cigarettes can contain anywhere from 10 to 12, 15 milligrams of nicotine. But on average, the average person absorbs about 1 to 1.5 milligrams of nicotine per cigarette. Nicotine is probably the most addictive and dependence-forming molecule known to man. The susceptibility to nicotine addiction is really multifactorial. So the combination of cultural, environmental, and social factors, plus people's genetic susceptibility, all play a role in determining how and if people get addicted to tobacco. There's many genetic studies that have tried to find susceptibility genes for nicotine addiction. I think the most commonly described is the CHRNA5 gene on chromosome 15. Mutations in this gene determine rate of nicotine addiction. Also, the CYP2A6 is responsible for metabolizing nicotine, and in some people, it's been found that the rate of metabolism determines sort of how dependent they are. So patients who are slow metabolizers have longer periods with nicotine in their system after a single cigarette, and they have less withdrawal symptoms, less cravings, and sort of less addicted or less dependent to nicotine compared to fast metabolizers. But these have not really borne out in many large scale studies. But I think by far one of the key drivers to addiction is the mode and the speed of delivery of nicotine to the brain. So as I said, cigarettes is a very efficient delivery system, and people that smoke cigarettes are usually much more addicted than people that use tobacco in other forms. And I mean, even if you think about people, when we treat patients with NRT therapy, they don't get as addicted to it compared to people that are smoking because of the delivery system. There are essentially two pathways that are involved in nicotine addiction, right? So there's the reward pathway on the right, and you have sort of the aversive pathway, which is the medial habenular interpedunculaire nucleus pathway. So it's postulated that depending on which pathway gets initially activated on the first person's sort of first few times they smoke, that kind of determines whether they keep smoking or whether they stop smoking or they don't continue smoking. But by far, the most predominant pathway is the reward pathway. So what happens is within 10 seconds of a puff of cigarettes, nicotine finds its way to the brain. It activates the nicotine acetylcholine receptors in the ventral tegmental area. And this causes the release of dopamine in the nucleus accumbens and the prefrontal cortex. So the dopamine reward pathway is activated, and this is kind of what gives people that initial pleasure and the desire to continue smoking. The MHB-IPN pathway is also activated. So if that predominates in the initial phase, people get the aversive symptoms like nausea and irritability, and they tend to not want to continue smoking. But repeated exposure to nicotine actually alters this brain chemistry such that the aversive pathway tends to get suppressed. It's postulated that when dopamine is released in the outer shell of the nucleus accumbens, that causes some mild euphoria compared to some other drugs of addiction that you can have intense euphoria from the first use. Cigarettes won't really give people that intense euphoria, but what happens is repeated exposure causes more activation of the nucleus accumbens core, and that's the part of the nucleus accumbens that's actually responsible for generating automatic impulses to smoke in the presence of cues. So that's more of like a learned conditioned behavior. Apart from dopamine, nicotine also increases the release of other neurotransmitters in the brain, including adrenaline, glutamate, serotonin, and other endocannabinoids that all have sort of positive effects. So this repeated exposure to nicotine causes sort of a cycle of reward where people get the pleasurable feeling from smoking that creates the impulses to smoke in the presence of cues. And for people, it will differ depending on what that is. It could just be the feel of the packet of cigarettes. It could be having the coffee. It could be driving to work. And this leads to positive reinforcement where people get sort of attached to those things as triggers to smoke. These all leads to an acquired drive from chronic and repeated rapid nicotine hits. When people are not smoking for any reason, like for sleeping or they're at work, with repeated nicotine hits to the brain, there's upregulation of the nicotine acetylcholine receptors. And when those receptors are empty, it creates kind of like a nicotine hunger or drive. If this is not satisfied, patients get withdrawal symptoms, which range from irritability, anxiety, depressed mood, anger. These withdrawal symptoms trigger, they kind of trigger the craving. And when you smoke, it gets relieved. So patients over time overgeneralize the symptoms such that when they feel these symptoms from other cause, they attribute it to needing a smoke. And this is very relevant, especially in the perioperative setting, where patients may be anxious for their surgery. And when you want to try to talk about smoking cessation, a common thing you'll hear is, oh, I don't think I can handle that now because of all the stress I'm going through. They are overgeneralizing their stress symptoms to needing cigarettes. And this all leads to learned behavior with weakened impulse control. So just to summarize the biological mechanisms, from repeated activation of the reward pathway, there's a damage to that pathway where people now form strong habits and have impulses to smoke in the presence of smoking cues. And with repeated use and upregulation of the nicotine acetylcholine receptors, people have this acquired drive or hunger that is relieved by smoking. And this promotes the cycle of abstinence, withdrawal, smoking, abstinence, withdrawal, smoking. And over time, abstinence is negatively reinforced and smokers misattribute any symptom of withdrawal to needing to smoke. And smoking then becomes a crutch to cope with stress. Now, given all of that, I'll just spend the next few slides talking about our work in the perioperative space with smoking. So we decided to sort of examine the profile of patients undergoing surgery, in this case, non-cardiac surgery, and look at smoking in this population. We utilized the available database of the VISION study. VISION, as some of you may know, was a large prospective international cohort study of over 40,000 patients conducted across 14 countries, 28 centers. Patients were above the age of 45. They were undergoing major inpatient non-cardiac surgery. And we looked at this population to determine how many were current smokers at baseline. In this work, we defined current smoking as smoking in the month before your surgery. So in 28 days before surgery, if you were smoking cigarettes, you were classified as a current smoker. And we did this so that we could actually capture people who are actively smoking. We found the prevalence of 14%, median parker history of 30 years. So these were pretty chronic smokers. Interestingly, even though these patients were undergoing surgery, over 2/3 of them were smoking on the day of or on the day before surgery. And only about 7% of the current smokers were using any form of smoking cessation therapy. Majority were nicotine replacement therapy before surgery, after surgery, up to the time of discharge. The prevalence of smoking varied by surgical type, as you can imagine, with vascular surgery patients having the highest prevalence of current smokers, neurology surgery and thoracic surgery following. We looked into self-reported abstinence at 30 days after surgery, and this was 38%. It was 40% at 1 year after surgery. Among those who returned to smoking after surgery, the median time to return to smoking was very short. Majority returned to smoking within 2 weeks after surgery, with a median duration of 7 days. 5 days for those who returned to smoking by 30 days, and 7 days for those who had returned to smoking by 1 year. We tried to look at factors that were associated with abstinence post-operatively. And one of the major factors that we found was, of course, proximity of smoking to the time of surgery. So patients who were smoking on the day of or the day before surgery were much less likely to be abstinent at 1 year compared to patients who had stopped smoking at least 14 days before. People that had cancer had a higher risk of being abstinent at 1 year, which we'll hope to expect. Patients undergoing thoracic, vascular, or urgent emergent surgeries also were more likely to be abstinent at 1 year compared to other surgery types. We looked into major vascular complications, which we define as a composite of death, non-fatal myocardial infarction, and non-fatal stroke. Patients who were smokers at baseline had a 13% higher hazard of experiencing this major vascular complication at 1 year compared to never smokers. So what we kind of learned from VISION was, hospitals are smoke-free environments, and it forces patients to be abstinent. And the surgical event itself can be a motivation to quit. And we say this because 40% abstinence at 1 year in this cohort study is much higher than we see in randomized controlled trials of smoking cessation interventions. Now, we can argue that, this was self-reported abstinence, so likely overestimated. And also, these are patients who were older. The median age in this population was 59. They had a lot of comorbidities. So for instance, about 23% had active cancer, which is kind of more than what you will find in the typical RCT for smoking cessation interventions. So yes, there might be some overestimation or the population might be slightly different, but it still sort of points to the fact that even despite low use of pharmacotherapy for smoking cessation, we had patients who had stopped smoking by themselves, likely because they were having surgery. So we see this as a significant window of opportunity to improve care. But there's still a lot of work to be done. And we know in our own practice that this is not even done consistently. So that led us to sort of try to figure out what the barriers and facilitators to perioperative smoking cessation intervention are. And we did this through a scoping review of the literature. A scoping review allows us to map the existing literature and just kind of understand what is going on. We did a systematic search and retrieved 31 studies. And we used the theoretical domains framework, which is sort of like a theory for behavioral change that helps us understand the why of behaviors. We included 31 studies that cut across different healthcare providers. So it wasn't just specific to surgeons. It was a combination of studies that looked at nurses, surgeons, anesthesia providers, perioperative medicine specialists, and patients. There were 23 identified barriers and 13 facilitators. But the key results from this scoping review was by far the commonest barrier to implementing smoking cessation in the perioperative period was limited knowledge. This scoping review included studies from the year 2000 to 2022. So it's not very old studies. And yet inadequate knowledge was the main barrier we found. Lack of time to deliver interventions in busy perioperative settings was another important barrier. Interestingly, we also found that healthcare providers believing that patients were too anxious about their diagnosis or their upcoming surgery to discuss smoking cessation was a barrier. And professional identity was also a barrier in the sense that in some studies, surgeons did not feel it was their role to provide smoking cessation advice or interventions to patients. And it's interesting because we know from other studies that even provision of brief advice by a healthcare professional can trigger quit attempts in patients. Interestingly, when we looked at the facilitators, it was found that where quit smoking advice was provided as part of routine surgical care, this was a major facilitator for smoking cessation. And patients themselves found the surgery to be a motivating factor. Again, buttressing the fact that the surgical encounter is a really teachable moment that we can capitalize on. So the next thing I would like to talk about is, what then are the existing perioperative interventions, smoking cessation interventions, and what is the evidence for their use? Just based upon the biology of nicotine addiction that we've talked about already, it makes sense that treatments for smoking cessation has to target both the physical addiction to nicotine by helping to reduce the positive reinforcement and alleviating withdrawal symptoms, as well as the psychological reliance and the behavioral aspects of tobacco use. Those two pathways have to be addressed in order to get the best outcome. And this, informs the approved treatments for smoking cessation. So FDA has 3 medications approved as well as behavioral support. So the treatments include behavioral support, nicotine replacement therapy, varenicline, and bupropion. Perioperative guidelines endorse this. They recommend that all smokers be offered counseling and pharmacotherapy before surgery, preferably 4 weeks or more preoperatively. The Canadian guidelines give this as a strong recommendation, but it's based on low to moderate sensitivity evidence. Behavioral support takes many forms. There are many different ways it can be done, either as one-on-one or group support delivered via mobile devices or even internet-based approaches. But the key thing is that it needs to address the psychological and social factors that usually are hindrances to people quitting smoking. By far, the commonest or most recommended techniques are motivational interviewing or cognitive behavioral therapy. However, we know that in reality, many of our centers don't have dedicated smoking cessation counselors, and it is left to the physicians to provide this. Many of us don't have the training to do this, but then we also know that even brief advice to patients about the harms of smoking and the benefits of quitting can be helpful. What is typically will be recommended in a busy perioperative setting that doesn't have a dedicated smoking cessation counselor will be to ask inquire about tobacco use, provide the brief advice, and then refer on to where they can get behavioral counseling. Whatever the case is, co-therapy with medication allows the patient to focus on changing behavior because the medications will deal with the physical addiction parts. Because nicotine withdrawal symptoms are a real trigger for relapse. It's very important when we're providing this advice and therapy to patients to let them know that they will feel these symptoms peaking in the first few days. They will start feeling it within the first few days. It will peak in the first week, but it will subside by the second week. It's very important because when we start them on medication or some sort of like counseling for smoking cessation, and they start to feel these symptoms, that's actually withdrawal from nicotine. Many times they attribute this to the medication. And you hear things like, oh, I've tried Champix, or I've tried NRT, the patch, it didn't work because I felt terrible. Yeah, they're feeling terrible because of the withdrawal. And if they don't know that they need to just persist and that it will go away, this usually tends to just make them go back to smoking because on one cigarette, they feel a lot better. So it's the drug caused me to feel bad. I felt better with cigarettes, so it didn't work. So it's very important for patients to know the time sequence in which to expect these symptoms. So, the commonest form of treatment we use is nicotine replacement therapy that comes in 5 different forms with different dosing schedules, and is typically dosed according to heaviness of smoking, with higher dosing for those who smoke more than 20 sticks of cigarettes a day. It essentially just provides clean nicotine and therefore helps to reduce the withdrawal symptoms, reduce the craving, and allows the patient to focus on the behavioral changes that will help them to become non-smokers. Combination therapy is highly recommended because, for instance, the patch will release nicotine very slowly. Don't forget the cigarette is a very efficient nicotine delivery system. So if they don't have short-acting nicotine to take care of the cravings, then patients will easily relapse. Varenicline is supposedly it's supposed to be the best smoking cessation medication, the most effective, It's a selective nicotine receptor partial agonist and partial antagonist. So it acts by binding on the nicotine acetylcholine receptors, releases some dopamine, so patients get some reduction in craving. However, it's also an antagonist at the receptor, so it doesn't allow nicotine bind. So when patients smoke, they have less of a pleasurable effect from the smoking. So when we start patients on varenicline, we actually tell them to continue smoking, cut down in the first week, and aim to stop smoking by the 8th day. Co-smoking with varenicline actually allows them to see how less pleasurable smoking is when they're on varenicline, and it helps them to actually cut down and quit. It's given for a total of 12 weeks. This can be extended even up to 6 months as necessary. The third approved medication is bupropion. This is an antidepressant. The exact mode of action for smoking cessation is unclear, but it inhibits the reuptake of norepinephrine and dopamine at the presynaptic membrane, and it just really helps to reduce withdrawal symptoms. It's most effective or most commonly used when patients have concomitant depression. However, its use should be used with caution in patients who have a history of seizures, as it lowers seizure threshold and can precipitate seizures in patients. So given these approved medication, we conducted a systematic review and network meta-analysis to determine which of them was sort of the most effective or the most efficacious in the surgical setting. Our systematic review, we found 21 RCTs that met our criteria, involving 3,594 participants. Our criteria were any trials involving patients undergoing surgery and where the intervention was started preoperatively. We looked at any intervention and we grouped them into 9 nodes. So we grouped behavioral therapies as brief or intensive. Brief if it involved counseling that was just 1 session or less than 15 minutes in duration. Intensive if the counseling was more than 50 minutes in duration or more than one session. And the brief behavioral therapies were commonly used in conjunction with pharmacotherapy, so that was accepted. We grouped computer programs in a separate node, decision aids, and then the pharmacotherapies in separate nodes as well. And essentially what we found, our primary outcome was abstinence at the time of surgery. And what we found was that computer programs and the intensive and brief behavioral therapies were the most effective for promoting abstinence at the time of surgery, with computer programs seeming to rank the highest in terms of efficacy. 30 days after surgery, varenicline had the highest odds of increasing abstinence at 30 days. However, the confidence interval was very wide, reflecting the low number of participants and events in that arm. Intensive behavioral therapy and brief behavioral therapy were also effective for abstinence up to 30 days after surgery. However, for 6 months after surgery, only varenicline showed effect for abstinence at that time. None of the interventions compared to placebo improved abstinence at 12 months. When we looked at post-operative complications, this was any complication reported by the studies. There was great variation in how studies reported post-operative complications. Some were grouped, some focused on infection. So we collated all the post-op complications, and we found that intensive behavioral therapies significantly reduced the odds of any post-operative complications. A subgroup analysis showed that when these were started at least 4 weeks before surgery, that had the biggest effect in reducing the risk of post-op complications with a positive the p-value for interaction that was significant. So basically what we learned from this was computer programs and behavioral interventions, plus or minus pharmacotherapy, which were all NRT, were most effective for preoperative smoking cessation. Using any of the first-line pharmacotherapy alone had the low probability of being the best method. So we know that just giving them drugs alone may not work as well. For post-op complications, intensive therapies started at least 4 weeks before were the most effective. There was very limited evidence for any therapy started within 4 weeks of surgery. Trials there were very small and didn't really have enough events. So we can't really draw any conclusions and say starting less than 4 weeks will definitely not improve post-operative complications. We just don't have enough data. Interestingly, there were no studies on a drug called Cessation. In the next few slides, 2 slides, I'm going to have a Menti, and I'll just ask that you please scan this on your phone and just try and answer the questions that will pop up. Let me start this Menti. If you just scan it, it will take you to the site, and then you just answer the question. I'll try not to answer because I was cute. Okay, we'll give it a few more seconds and then we'll move on to the next. Okay, I think it's safe to say that okay, with no more answers coming in, I'll move on to the second. I think this kind of answers the second question because the second one is, well, I mean, if nobody answered yes in the previous slide, I don't know that we'll have anybody answering yes to this one. But I'll just give it 10 seconds just in case. And I'll try not to answer myself. Okay. So I think it's safe to say that many physicians, which has been my experience outside of this, don't really know about this medication. So it's a plant-based alkaloid. It's a natural supplement. It's a partial nicotine acetylcholine receptor and agonist and antagonist, just like varenicline. In fact, it was the structure on which varenicline was developed by Pfizer. It has been used in Eastern Europe for many years, since the 1960s. Many trials have been done with it in Eastern Europe. Initially, the early trials did not quite meet Western standards for good good trial practice. However, since 2017, it has been approved by Health Canada as a health product for smoking cessation. It's the cheapest of all pharmacotherapies, costing about a sixth of the cost of varenicline. And there's been RCTs that have shown its superiority to placebo, NRT, but still underutilized despite RCTs. So what we've done is to update, to conduct a systematic review and meta-analysis of the safety and efficacy of Cessation. This was just recently published. Our systematic search found 14 randomized control trials published in the New England Journal of Medicine, in JAMA, and other high-impact factor journals, including almost 10,000 patients. Our primary outcome was biochemically verified abstinence at 6 months. All this inclusion criteria for trials were trials involving adults above the age of 18 who were going to quit smoking and did not have any sort of did not have any allergies to Cessation. Our primary outcome, we found that Cessation was more effective than placebo with a relative risk of 2.25. It wasn't significantly different from varenicline, even though the relative risk was 1.13. Abstinence at longest follow-up, which was at 12 months for many of the studies, we found that Cessation was more effective or superior to placebo and NRT, but not significantly different from varenicline. With regards to adverse events, most of which were gastrointestinal adverse events like nausea, vomiting, abdominal discomfort. Some other adverse events included things like abnormal dreams, which is common with varenicline as well. We found that Cessation had more adverse effects than placebo and NRT, but significantly less than varenicline. So basically, Cessation proved to be an effective and safe drug for smoking cessation, better than placebo and NRT, not very different from varenicline, but with fewer side effects than varenicline. Given that this medication is approved for smoking cessation in Health Canada, is cheaper than varenicline, it's really interesting that many of us don't know about it and we're not using it. So far, what we've talked about, we've shown that smoking is prevalent among surgical patients. It increases the risk of postoperative complications. Nicotine is the psychoactive substance in tobacco that is highly addictive and is what sustains smoking. We have encouraging data that shows that the surgical encounter itself can promote quitting. There are some barriers we've identified. We know that smoking cessation interventions can promote abstinence and reduce post-op complications, but we still don't have any evidence for some of the sort of newer medications in the surgical population. So what I think our evidence gaps are, do we need more pharmacotherapy to increase the options that we can offer patients? If we do, I think Cessation is a good option to explore. It is cheap, it's a natural product, it's safe, and it's effective in non-surgical population. Because it's cheap and it's a natural product, maybe there might be more uptake amongst patients who, are sort of prone to wanting natural alternatives to medication. Can we just extrapolate findings from the non-surgical population to surgical population? I would argue not, because we've had various experiences where interventions that work in non-surgical populations have just not shown the same effects in surgical populations. And the common one I will draw your attention to be aspirin. So we all know that aspirin is recommended for secondary prevention in patients at high cardiovascular risk. However, we know from the large POISE trial that giving aspirin around the time of surgery, not only in patients who were at high cardiovascular risk, it did not reduce major adverse cardiovascular events, but it even increased bleeding. So there's differences in surgical populations that we can't just assume will be the same. So for instance, in the case of this medication, patients may have tolerability issues post-surgery with nausea, vomiting that's common after surgery, and having a medication that may increase this. We don't know what the effect will be. Patients will have other competing health demands, and maybe smoking is not their priority, or maybe taking the medication for smoking is not their priority. So we have to understand how it works in the surgical setting before it can be a recommendation. Another gap is we know that intensive behavioral therapy works, but we also know that in our busy clinics, we don't do this. So is there any time efficient way that we can provide patients with the counseling that they need that will overcome the barrier of knowledge, expertise, and time in the perioperative setting. So this, to me, is where sort of the future research in this field is. And we are doing this research. I just want to remind us, like, this is a picture taken from the Toronto Star in 2018, showing patients obviously smoking in front of a hospital that has no smoking signs. 2023, I can guarantee you that we still have this in all our hospitals, Juravinski, Hamilton Health Sciences. We still have patients coming out for a smoke. And if they're smoking outside, it means that we have a lot more work to do inside. And we're taking this on. So we're looking at, we know that pharmacotherapy with behavioral therapy is what we should do. So we're looking at a cheap, safe, effective medication called Cessation, going to look at it in the surgical setting. And then we're going to use personalized video messages to try to provide behavioral counseling in a more efficient way that is less dependent on face-to-face sessions with physicians in the pre-op clinic, and that is more accessible to patients where they can watch at a time and place of their own choosing. We don't have any perioperative trials that have looked at these strategies to inform on this issue. And that's where we have our trial called PREVENT. So PREVENT is a perioperative smoking cessation trial. It's designed as a 2x2 factorial RCT to assess the efficacy of Cessation versus placebo and behavioral counseling delivered by personalized video messages versus standard care among patients who are undergoing surgery within 28 days. We have funding from HASO and PHRI to start the Vanguard phase that will include 100 patients. Our full trial, if the Vanguard proves to be feasible, will include 1,700 patients across many countries. This is just a flow diagram of the proposed trial, where we'll identify patients 28 days before their surgery, if they are adults and give consent and they're current smokers, randomize them to citizen or placebo, give them the intervention for 8 weeks. Also in the factorial, randomize them to video messages versus standard care, again for 8 weeks. Primary outcome measured at 6 months, and this will be smoking, biochemically verified continuous abstinence from smoking at 6 months. The feasibility, the pilot trial or the Vanguard phase is to test the feasibility, and our trial will be feasible if we're able to enroll at least 2 patients per center per month and achieve 90% follow-up on more than 90% of them. We have other outcomes for the full trial, which are secondary smoking outcomes as well as post-operative complications. So in conclusion, I would like to just reemphasize that smoking is a leading risk factor for mortality. It increases post-operative complications, is still too common among surgical patients. Very few smokers are currently treated. Most of them resume smoking after surgery. We know that smoking cessation interventions in surgical settings are effective if they are intensive and start at least 4 weeks preoperatively. However, in reality, many of our patients are seen too close to the time of surgery. So we need new strategies that will inform on these timelines that are consistent with current practice and that can address some of the barriers that we've uncovered. Our trial, PREVENT trial, will start recruitment in October of this year, and we hope that it will provide evidence to inform this issue. Given all of this, we still need future implementation studies in this area to determine the best way to implement smoking cessation interventions. I'll end by with a quote from Richard Edwards that's published in the BMJ, where he says, encouraging smoking cessation is one of the most effective and cost-effective things that doctors and other health professionals can do to improve health and prolong their patients' lives. All of this work was supported by the Perioperative Care Research Group led by Dr. PJ Devereaux, PHRI, HASO, and the Department of Medicine Early Career Award that helps to support my research. I thank you all very much for listening, and we'll open to discussions. I'll stop sharing so we can see everybody.
Thank you, Dr. Ofori, for this overview and sharing your research and the evidence and the literature in your practice. Fantastic. So if you have a question, please put it in the Q&A, or if you want to ask your question, if you want to ask your question in person, please raise your hand and I'll bring you in to allow you speaking. And we'll also monitor the chat if there are any comments.
I see that there's a question there's questions in the chat from Dr. Kearney. Dr. Kearney, do you want to unmute yourself and ask your question.
Yeah, Dr. Khan has a loaded question here. We can bring in Greg. Greg, go ahead.
Thank you so much for your insights. I think one of the things is that most patients feel the cost of smoking cessation products are expensive. Government provides some limited support. STOP program comes and goes. Right now, I think it's restarted. And who's eligible to get free nicotine replacement therapy? How to get them started? And how do you follow up in your... And many people have more than one problem. And to say that people have no information about smoking, we're crazy. I mean, there's so many, everybody knows smoking's bad for you. So the question is, how do we move that forward? Maybe they don't believe it or they don't want to believe it, but I want some deeper levels because, people have multiple addiction problems. There's some talk about that, that we have other agents as well. And one is Ozempic is being touted as being an agent as well. So I wonder if you could expand that a little bit. And how does a specialist get access to smoking cessation products?
Yeah. Thank you. These are all very, very good questions, and I'll try to take them one after the other. With regards to cost, this is a common sort of issue that we hear patients talk about. And before we did the scoping review, I believe that cost would have been one of the major barriers we found. But interestingly, cost was not a major barrier we found in the scoping review. However, the caveat is that in that scoping review, many of the studies were done in high-income countries. So that might be something where if it's covered by their national health insurance. I know in Canada, the coverage is very variable. Patients are eligible for NRT or varenicline, usually one cycle in a year. So there's limited coverage for that. But I find also that the issue of cost as a barrier, if you try to break it down, it's not really as real as we think it is because it is more expensive to smoke. Even if they're getting cigarettes from, cheaper areas or whatever, it is still much more expensive to smoke. So when you help patients actually see what the actual cost in dollars is for therapy versus what they're spending on smoking, it helps to put it in perspective. So that's one thing I'll say about cost, because this is something we discuss a lot in clinic. With regards to how we access NRT, we have the STOP program, as you mentioned, in Ontario, is live and active. Patients need to be enrolled in STOP. I find that I put a link in one of the slides, the Stop on the Net program is a free sort of government-funded program where eligible patients, again, this is just basically anybody who's smoking and wants to quit, can access free NRT for up to 26 weeks. And they actually give combination NRT. So it's actually a very good program. The only thing is that patients have to be enrolled and they need a valid email address and house address to enroll. So again, this speaks to some equity issues because some patients who smoke have other social issues and housing is a big one. So what we've done is we're trying in Hamilton Health Sciences to incorporate the STOP program into our clinics so that patients obtain the NRT from us through STOP. We're still hoping Dr. Khalid will help us with that, but it's a plan that's ongoing. But right now, what I'm doing in clinic is I'm enrolling patients when I see them in clinic, and the few ones I've seen have valid email addresses so that they can be connected with the STOP program and they get the free NRT. So that's one way that patients can get free NRT. With regards to patients being on multiple things and having multiple addictions, this is very correct because smokers who have other addictions are much more difficult to help than smokers who don't. And having any sort of mental illness increases the risk of smoking and increases the odds that smokers will end up being heavily dependent on tobacco. And that is why programs that deal with mental health need to have tobacco cessation incorporated. Unfortunately, that's not the case. In many mental health programs now, tobacco is not the priority. It's almost like this is all that they can use to cope. So they don't want to take that away from smokers. Again, there's lots of literature documenting this and looking at how this is the opposite of what we should be doing. So I agree with you, it's a much more difficult population to deal with, and they need more comprehensive addiction services as opposed to just like an advice from a doctor in the clinic. But until we have a comprehensive service, I think that every encounter with the patient should be an opportunity to bring up smoking cessation and not just bring it up, but actually help advise and refer them on to where they can get the help that they need for smoking cessation. With regards to the GLP-1 agonists, there are some studies that are showing that GLP-1 agonists also reducing improving smoking abstinence. There's still mechanistic studies. It's not yet established. I think it's an interesting area. I'm not sure what that will show in a couple of years, but yes, there are some studies showing that GLP-1 agonists have some efficacy in smoking cessation.
Your computer programs, do people have access to that?
Oh no, so those were what we found in different, so it depends on the area. So like the studies that looked at computer programs, so in the US, where there are some hospitals that have them incorporated into their EMR, where patients, while waiting in the preoperative clinic, can access these programs and sort of have like a computer-based counseling session. But I don't know that any center in Canada has this or is implementing this yet. So I'm not sure.
Thank you
So much,
Sandra, for covering this excellent questions. Dr. Herzstein has a question, so go ahead, Herzl.
Yeah, first, Sandra, that was a wonderful presentation and very comprehensive and a great trial. Just a comment and a question. The comment related to cost. It's actually fascinating that every single cardiovascular outcomes trial that has been done in people with diabetes, and diabetes itself is a strong risk factor for serious outcomes. You see 15% of people at baseline are smokers. And diabetes is another opportunity, just like surgery is, to tell people about smoking cessation and the importance to do that. And we do that all the time. And from a cost perspective, I always tell patients that a pack a day is one cruise a year on a good cruise ship. So in terms of cost, if they can afford a cruise, or if they want to afford a cruise, they can still pay some of that for the drugs. Oh. So that's the comment. The other 2 points is that there was an article this month in Scientific American, actually a pretty good one, about smoking. There's a whole section this month on Scientific American on smoking. And one of the comments that they made is that we don't know whether or not the adverse effects of smoking are due to all the crap that goes into your lungs with cigarettes, or whether it's a nicotine thing. The nicotine thing is the addictive part, but we don't know whether the harms are due to the other things. And I always worry about the law of unintended consequences when you get people, even in your trial, to stop smoking. They're going to just substitute vaping for it, which is pure nicotine, as opposed to what they're getting with cigarettes and everything else. So the question is, how can you prevent that sort of unintended consequence of smoking cessation? Because you can understand how people's minds would quickly go to that. Are you building that into your trial? Yeah, so that's really the issue that I think, because we don't know what the adverse effects of nicotine alone are.
Yeah. Thank you very much for those comments. And I think I'm going to start using a pack a day because of the cruise. That's a really good one. Thank you. So with the question, I think there's many studies that have shown that the crap in the tobacco is really what is mostly responsible for most of the adverse effects. The nicotine is what keeps them coming back to the crap in the tobacco. Nicotine itself, being a stimulant, has its own sort of adverse events, which include things like vasoconstriction, slight increase in blood pressure. So it's not completely benign, in so to speak. And that's one of the reasons why in the early 2000s, perioperative providers were really reluctant to start NRT close to the time of surgery because of this idea that nicotine itself has its own problems. But we also know that when patients are abstinent at any, from any period of time from tobacco, the nicotine hunger drives them to seek nicotine. And if they flip to vaping cigarettes or e-cigarettes, the problem with that is there's so many variations of e-cigarettes. So for instance, a single cigarette contains about 10 to 12 milligrams of nicotine. Some of the cartridges have up to 150 milligrams of nicotine. So you're completely correct, where if patients flip to e-cigarettes or vaping, they are potentially exposed to much more nicotine than they even used to with smoking. So that's a problem. And that's why, e-cigarettes, even though they have been touted as a harm reduction strategy and are adopted in places like the UK, in Canada, it's not approved as a harm reduction strategy yet because there's so much harm that can come from e-cigarettes. In our trial, we anticipate, obviously, that in any trial where you're going to ask patients to stop smoking, we anticipate that they're going to have withdrawal symptoms and nicotine craving. The good thing about Cessation is that Cessation is a partial agonist and antagonist, just like varenicline. So it does provide some reduction in that craving experience, and it helps to reduce withdrawal. And it's dosed, the way it's dosed is that in the first few days of the medication is dosed more frequently than during the latter parts of treatment. And the idea is it has a short half-life, about 6 hours. So you want to have, constant levels of cytosine in the system to help to saturate those receptors as much as possible to reduce that craving. Again, hopefully we'll show that we can reduce this. Many smoking cessation trials have abstinence rates in the 20s. So there's a challenge with that because patients many times still go back to smoking. But I think every win in this space is a win. So I don't know, we'll see what trial shows.
Thank you.
Thank you so much, Dr. Ofori, for addressing the questions. And again, thank you. We're on time, so thank you very much for your presentation, sharing your experience and your research with this very important topic that we all experience in our clinical practice. And thank you very much, and have a great day, everyone.
Thank you so much for having me. Thank you, everyone. Bye. Thank you, Carla.